Good evening. This is Dr. John Bennett, broadcasting from Miami, Florida. Tonight we have the first in the channel of head and neck surgery for Larkin Hospital TV, in an innovative way of medical education. And before we turn it over to Sajish, we'll let the panel go one by one and introduce themselves. Good evening, Fight.
Hi everyone, my name is Faik Sheikh. I am a molecular imaging physician by training and involved in biotech entrepreneurship. I have been involved with internetmedicine.com and the TV channels. Happy to be here as one of the panelists.
Yeah, I'm glad to say Faik's going to be involved with radiology TV as well as med informatics TV. And Faisal, welcome. Could you introduce yourself, please?
Yeah, sure. Thank you so much. Can you hear me?
No, a little bit louder, I think. Try again.
So, Dr. Bani, my name is Faisal, and I'm working as an intern here in Pakistan.
Okay. Welcome, Faisal. Curry?
Hi, my name is Korikose Korean. I'm a health informatics student. Just hope to get some good information, and that's it.
Yeah, he's a youngster that's going to help Fike with the medical informatics channel, and is also the son of our main speaker. Welcome, Sajish.
Thank you, John. I'm Dr. Sajish Korikose. I'm a head and neck maxillofacial surgeon by profession. And I've been involved in doing a lot of head and neck surgeries in the past. I traveled all over the world, and I was involved in setting up some major head and neck units. Now today I would like to talk about my experience, particularly some experience which I had, which was fascinating. And today I'm going to talk about my experiences in the Middle East, where I worked for approximately 5 years on and off. So I'm going to go into a PowerPoint presentation now. Thank you very much, John, for having me today. And today is a big day for us, because this is the first program of the head and neck channel. And okay, I'm just going to do a screen share now.
Okay, we hope to have many more.
Okay, right, okay. Can you see my PowerPoint now?
Not yet, not yet. Try it.
Not yet?
Yeah, try again.
Try again, okay. So let me just close it.
Okay, we're all rookies at this technology.
Right, so I'm going to click screen share and
click
and then
share,
and then
pick the screen.
Hit the screen.
Mm-hmm.
Okay, has it come?
Not yet. Not yet.
Not yet. Okay,
Not yet.
I'm going to.
We'll get it. We'll get it.
Did you get it?
Not yet.
Not yet. Okay. Right. Let me just try to go back and do once again. Let me do a screen share. Oh, there we are. Got it. Share.
There you go. There you go. There you go.
Yeah. All right. Okay. I'm just going to try putting it on a slideshow. Let me see. Is it good now?
Yes.
Can you see it?
Yes. Very clear.
Oh, very good. Excellent. All right. Okay. So, all right. Okay. So I'm coming back to our first Hangout Head and Neck channel meeting on 7th of July 2015, 6 p.m. Florida time. And my name is Dr. Sajish Korikose. I was working as the chief of a head and neck unit and a consultant surgeon. And I want to talk today about my experience in the Middle East. So I was involved in setting up a head and neck unit in the Middle East area. And in this unit, our work consisted mainly of acute head and neck trauma and we used to take all sorts of road traffic accidents, and this was the majority of our workload. Now, we also did a lot of post-traumatic reconstructions, and we did a lot of correction of congenital facial deformities. We did a lot of, there was a lot of cleft lip and palate cases, which I'm going to highlight today, because this was supposed to be a small part of our work, but it exploded into a major chunk. And finally, we have a lot of head and neck tumor resection and reconstruction. It was a pretty busy unit. And the main thing which I want to talk today is about the management of the cleft lip and palate and the emphasis we had about these cases. And I'm talking about my experience, particularly in Saudi Arabia. Okay, now cleft lip and palate is one of the most common congenital abnormalities, and if you look at the worldwide incidence, you can see that it's the lowest among the black race, and it's about 1 in 1,000 live births. In the Caucasians, it's about 1 in 700. In the Orientals, it's about 1 in 500. But in the place where I was, which is the eastern part of Saudi Arabia, it was about 17 cases in 1,000 live births. This is one of the highest I've seen in my life. And this is the article which I found. There are not many articles about all these. There's not much statistics or anything available, but this is one of the articles which I managed to find. And the incidence is 17 in 1,000 live births. So in one short visit, when I go there, I normally go there for a month or two. In this particular visit, I saw about 16 cases, out of which 4 were male, 12 were females. So we had a female predominance of 3:1. Now, our statistical conclusion was the commonest clefts are isolate clefts of the palate. There's a predominance of the right side clefts, and there's a predominance of females over males. But if you look at the worldwide, now I want to just compare the cleft statistics. Worldwide, the commonest cleft is the unilateral cleft lip and palate. But in Saudi Arabia, the commonest cleft was the isolated cleft of the palate. Now, there's a predominance of left side clefts over the right side clefts. But in Saudi Arabia, the right side cleft is more than the left side clefts. Also, worldwide, there's a predominance of males, but in Saudi Arabia, there's a predominance of females over males. And also, another important finding was the incidence of other congenital abnormalities associated with cleft lip and palate cases, which is about 21% all over the world. In Saudi Arabia, we found that this was slightly higher. It was in the range of 25%. So, oh, sorry, I went, okay. Now, the problems were with any cleft, and in particular in which we were facing, were the feeding problems, airway problems, and high incidence of middle ear infection, which is what you expect. So we used to import all these different types of nipples, especially used for cleft lip and palate, and this is one of them, the Haberman nipple with an enlarged hole. And when you come to airway problems, we have a lot of Pierre-Robin sequence associated with it, and Pierre-Robin syndrome is always a situation where there's a micrognathic mandible, and they are always prone to airway obstruction. So we used to put these patients into prone position, and sometimes we had to go ahead with surgical management, which used to be either a lip-tongue adhesion, so that there's no fall back of the tongue, or sometimes we used to go into a tracheostomy And when I left Saudi Arabia, I just introduced the concept of distraction osteogenesis, which means you just lengthen the whole mandible and you reposition the back of the tongue, and so and the tongue does not fall back. Okay. So coming to the middle ear infection, which is a common problem in the cleft palate, it's because of the abnormal cleft palate anatomy, affects the functioning of the eustachian tube, and it increases the, it increases the incidence of middle ear infection, and you can end up with hearing loss. So ENT consultation is very important. And there are associated problems like other medical problems. The incidence is normally about 21%. In Saudi Arabia, it was about 25%. Now, my whole concept was about building up a team for managing any problems. So I am a firm believer that the associate specialties should all come together, and that's how I started this unit. We used to have ENT, ophthalmology, neurosurgery, plastics. We had speech therapist. We had all sorts of dental, and it used to be, a common ground. So we got all the specialties together around the table, and we put up a problem, and we look for solutions from different aspects. And this really helped us to solve a lot of issues with these complex cases. So a team approach should really be, you have to have a lead surgeon, which could be a head and neck or maxillofacial or plastic or whatever. You need an ENT surgeon specialized in middle ear, especially who's interested in otology. You need a speech therapist. You need pediatrician because most of these cases have got other medical problems. You need an orthodontist. You need a pediatric dental specialist. You need a social worker. So this is how we made the team. And the contribution of the nurses, everybody, because without educating the nurses, without educating the parents, and without the help of the social worker, we would not have achieved what we have achieved, and that's what I'm going to show you now. All right. So when we look at the management protocol, we selected this management protocol. What we're going to do, we do pre-surgical orthopedics at birth, do the cleft lip repair at the age of 5 months, palate repair at 7 months, pharyngoplasty at 4 years age, cleft bone grafting 7 to 9 years, maxillary osteotomy for advancement of the maxilla at 16 years, rhinoplasty and lip revision at 18 years. This was our standard protocol. This is slightly different for bilateral, but I'll come to that later. So if you look at the normal anatomy here, you can see that this is how all the muscles, and in a cleft you can see there's a detachment here, and all the muscles are pulled apart, and that's the anatomy there. Now, if you look at the history of cleft lips, there was a straight repair of Rose Thompson, then we went into the triangular flap, then we went into the quadrilateral flap of Haig John. Then the big revolution was the Millard's rotation advancement flap, but after that there was a big change that happened, and this was with the introduction of the Delair's functional repair. And another important factor was the Mulligan nasolabial repair, and this was modified by cord cutting in New York, who is in New York, and this was in 1998. Right. So I stick to the classic Millard rotation advancement technique, and this is basically the incision for it. And you get a good lengthening of the columella by the C-flap. The back cut is done, and it get very good lengthening of the lip on the cleft side. It's an easy technique to execute, and the results are fairly consistent. But Dallaire in 1975 totally changed our concept. His basic principle was, if you have normal growth, if you have normal function, you have normal growth. If you have an abnormal function, you have abnormal growth. So the emphasis should be on functional repair. So a normal function results in normal growth. So what you want to do is you want to create a normal function. So this was the whole concept of the functional repair. Now, coming back to the earlier slide, you can see all the muscles are there, but they are not attached to each other. All you have to do is that put every single of them together, and then you don't worry about the cosmetics now. Get the function right. This is the whole concept of Dallaire's functional repair. All right, this is a wee boy who had an incomplete cleft lip on the left side, and he's on the operating table now, and you can see my intra-op markings, all the markings, and that's the, oops, one second, I did something wrong. Right, okay, you can see the advancement flap taken, and that's the rotation flap, and here we are doing an intraoral mucosal repair. You have to build a good sulcus, and you have to do a good mucosal repair, and then you have to take every single muscle. I take all the nasolabial muscles, all the lip muscles, I put everything together. I used to do a lip in 20 minutes. Now I take 3.5 hours to do a cleft lip. So basically, it is a functional repair. Every single muscle is repaired. We believe that if you have good function, you have normal growth. If you don't have good function, you don't have normal growth. And at the end of the day, what matters is whether you get a good growth. You can do a very good plastic repair without doing a functional repair, and you can end up well, initially it'll look very good. Many years later down the line, you'll find that the whole face is totally asymmetrical and not acceptable. All right, so this is one of the cases which I did. It's a pre-op on the left side and a 1-week post-op on the right side. And if you look from below, look at this big bulge of muscle here. See, that's a nice big bulge of muscle. Just because this is an incomplete lip, don't think that this is going to be easy. You have to take all the muscles out of here, all the nasolabial muscle, all the lip muscles, everything, and you have to put everything together. You need to get a total functional repair. Okay, that's a 3-week post-op, and this is a 3-week post-op here. Pre-op, you can see. Okay, another case. Again, there was a lot of. This is also a incomplete cleft lip. I don't know. I ended up with a lot of incomplete cleft lip, and they always used to ask me, "Why do you want to do such a huge repair for these cases? It's simple. Just put the skin together." No, this is one case there which we did a gingival periosteoplasty. This is one of the new techniques which Dr. Dallaire was promoting, and this actually helped us to avoid doing a cleft alveolus repair. So the markings for the surgery, I do it as if I'm doing a complete cleft lip, and here we are. This is the post-op, and I always put a nasal bolster and a nasal pack. So that's the pre-op and a 3-week post-op. And again, the same patient, 3 weeks post-op. Oh, I have something, a 7-month post-op as well. Yeah, that's really unusual. So, sometimes when I go back, I see these cases, and I'm sorry, I should have off my phone. Forgot. Right. So that's a 7-month post-op, and this is 7. You can see now the muscles have started functioning. See the good bulge I got here. Look at the nasal symmetry here. Now the nasolabial muscles are functioning here. That's what you want to get, and it's worth spending a few hours to get these cases together. That's a 7-month post-op. Okay, now bilateral is twice as difficult to repair, and the results are only half as good. This is what James Barrett Brown said in 1947, the great British surgeon. And the protocol is slightly different. We start slightly late. We start at the age of 8 months, but more or less the rest of the surgeries are the same. So actually, it's not a single surgery. It's a series of surgeries done at the right time. And another thing which really changed the whole management was the premaxillary positioning, and this makes the surgical corrections very easy. And this is Latham's appliance, which was developed by Ralph Latham, who is an orthodontist, and he is in London, Ontario, in Canada. And I went and visited him, and he showed me a lot of his cases, and I was very impressed. And at that time, I took that opportunity to visit the Children's Hospital in Toronto, and they were doing something different. They used to just use this little elastic traction, and the results were fantastic. I tried to do the Latham in Saudi Arabia, but due to some problems, management problems, they were not able to get the Latham appliance, and we had to resort to these little sticky. And here's one of the passive premaxillary repositioning traction, and this is how we started. And if you look here, this is a bilateral cleft lip and palate, and look at the premaxilla jutting forward. The reason for this coming forward is because there's no muscle holding it back. The muscle is detached. And here you can see the premaxilla jutting forward, and you can see a huge gap between the premaxilla and the rest of the maxilla. Look at the gap here. All right, so I started using this little traction, elastic traction. I started at the age of 3 months, and here, look, now we are 1 month into the traction, and look at the that's how we were improving. And before we started the traction, it was about 1 centimeter gap, and after, we almost closed the gap. This made the surgery very easy. All right, so also look at the angulation. Now this was kind of rotated. When I finished the premaxillary traction or repositioning, look at the symmetry. So it's a nice maxilla to a nice bilateral cleft lip to repair now. And the patient is ready for surgery. And I do the Mulligan's repair. Mulligan is a great surgeon. He's in Boston. I spent a little time with him as well, and I thought his technique was fantastic. So I adopted that technique, and this is how we do this bilateral cleft. And I incorporated all the principles of Dillard surgery. And look, it's a you have to take every single muscle. It's like a major undo of what has happened and putting everything together. Look at this is not how I used to do a bilateral cleft lip. I used to do finish a cleft lip in 40 minutes. Now I take about 3.5, 4 hours to do a cleft lip, and this is how it looks like a major reconstruction procedure, and it's worth doing it. Look at identifying the muscles, and this is the child pre-op, and here I have a 3 months post-op. I have a 1 year post-op here, so probably I got a picture after I went back, and probably the child was 1 year. Many of these parents come to see me, and they come and find wherever I'm working. They come and find me, and they come and visit me, and they are very hospitable people. I had a lovely time in Saudi Arabia. And yeah, I actually have a 2-year postdoc. That's wonderful. So I have a pre-op, I have a 1-year postdoc, and I have a 2-year postdoc. So that's very, very rare for me to have a 2-year postdoc. So there you are. I have a 1-year postdoc here and a 2-year postdoc, and you can see this girl is developing into a beautiful young lady. And palate is again one of my most passionate areas because of the problem of speech. And you can see in the palate, this is a normal palate. You can see all the muscles are put together. In a cleft palate, it's all apart. So I normally do a Ward-Wardle VY pushback of the palate, and that's one of the cases. But always remember, I do a complete dissection of the muscle. I take all the tensor palati, the levator palati, all these muscles. Look at the palate during surgery. This is it looks like a major surgery. Look at the levator palati, look at the tensor palati. Each muscle is identified. They're all put back together, and that's what gives a good speech. Now, the whole aim of a cleft palate is not to close it, but to give good function and good speech. That's the emphasis. Right, okay, now this is another palate, and again I want to emphasize on the concept of a team approach. My cleft team was, well, actually we had many teams there, but the cleft team consisted of head and neck or maxillofacial or plastic. When I was there, I did most of the clefts there. We had an ENT surgeon who used to check the hearing, check the middle ear. Always we used to put grommets into the middle ear so that the pressure was equalized, and we reduced the incidence of middle ear infection. We had a speech therapist from very early. The child started speech therapy as soon as speech started. We had a pediatrician who would check the child and make sure there's no other medical problems. We had an orthodontist who used to come in and help us out with a lot of these repositioning of the abnormal maxilla. We had a pediatric dental specialist. We had all these children had a lot of dental caries, so they used to have a lot of rehabilitation. We had a social worker. He used to interact with the parents. This was all new in Saudi Arabia, and our unit was one of the coveted units in the country, and we had a special recognition for that, and that's it. So thank you very much for listening to this presentation. This is my little experience of cleft lip and palate in the Middle East, and I hope you enjoyed, and I'll be happy to take some questions if you have. Thank you very much, John. Thank you, Faik. Thanks, Faisal. Thank you, Kuri. Thanks, everybody who attended this talk.
Very good, Sajish. Excellent. The head and neck channel is in good hands. And I know as a regular doctor, I'm not a surgeon, and none of us are surgeons on the panel, but as a doctor, and I'm sure your son can appreciate the training that you put in to do such precise surgery, and the time, and I hope you can spread your knowledge, and I hope we'll have in the future head and neck surgeons on the panel. So let's open it up to questions. Any questions for Sajish?
Well, I'll just take a question. Faik, you have a question there?
No, no question in particular. I just wanted to congratulate you on a nice talk, and it serves as a nice starting point for the channel. And yeah, I hope that you get to see more head and neck surgeons, chiming in and contributing in their capacity from within the US and outside, so that the dialogue can begin. So yeah, best of luck to the channel and everybody involved.
Very good.
Thank you, Faik. Yeah, that's thank you very much for the compliment. Yeah, it was a great experience in the Middle East. I must say. But I want to, my whole emphasis is on a teamwork because, any deformity, any tumor, any fracture, there's no boundaries. I mean, we set the anatomical boundaries that this is ENT, this is ophthalmology, this is dental. No, the diseases and the pathologies don't have any boundaries. So you need different specialties together. So this is my emphasis on the whole thing. It's a teamwork, and we used to put the cases on the table, get everybody together, and we used to take all the input from everybody, and we used to plan it. And this is not something we developed in a day or two. I had constant meeting with people. I wish I had hangouts at that time, which we didn't have. But, yeah.
Well, Sajish, you'll not only be able to share with other people, but outlying head and neck surgeons in very rural parts of the world will be able to participate also. They can't get to a conference or university center. So hopefully Hangouts can fill a need there. One quick question, Sajish. Did you have to operate under a microscope for that? It seems to be pretty meticulous suturing.
Yeah. That's one thing I forgot to say. Yes, when I started, I was using magnification, which was loupes, but now I only use an operating microscope because the magnification is much better, and but you have to get used to the concept of looking straight and operating below. Okay. So you have to change your mindset totally. But yes, I use an operating microscope. And it's a little difficult when you're doing a cleft palate, but that's where I found it most useful. You practically put the microscope into the mouth, and it has to, focus on the posterior palate, and you want to get all your muscles, your tensor tympani and your tensor palatae and all from the skull base, and bring it down and reattach it and get it working. So that's the whole idea.
Yeah, cleft palates are done by plastic surgeons too, correct?
Oh yeah, I used to have a lot of plastic boys who used to train with me. They used to come and learn, and I train anybody who comes under my wings. I take plastic surgeons, I take maxillofacial, I take anybody who's interested in learning. But I wouldn't take somebody who's interested in burns. And they want to do one palate once in a while. No, if they come under me, I would like them to do a high volume and be in the field rather than being a general plastic surgeon. I would like to call them a cleft surgeon. Yeah.
Right. Okay.
Yeah.
Has there been any robotics in that part of surgery? You know that robotics are used in other parts of the body.
Yeah, well, we started robotics for a lot of colon surgery and a lot of abdominal surgeries. Right. But no, we actually did not do any robotics for head and neck tumors. Okay. I suppose it's one field which has not taken off and probably would. I'm not sure. I'm out of the game now for the last 6 months, so I'm not really sure what developments have happened. But when I left, we actually did not start any We had robotic surgery in our unit. Actually, Saudi Arabia, in many units, they have robotic surgery. They love technology, so they buy all the technology.
Well, hopefully we can bring it to them in Technicolor. Curry, you're kind of quiet back there.
Yeah, I was just listening to the lecture. It's the first time I'm seeing this also.
Well, I guess your dad spent a lot of time in the operating room, right?
Oh yeah, a lot.
Did you ever scrub in with your dad?
No, not at all.
Oh, okay. More into informatics.
More into the informatics.
Okay, very good. I know you have to go off to dinner, Sajish, so I thank you very much for the great first show in head and neck surgery, and we look forward to more.
Thank you very much. Yeah, thanks a lot. It was a pleasure, and it's really an honor to be the first speaker on the Head and Neck channel.
Okay, we're on the way. We're on the way. Good night, everybody.
All right, good night.